Hey everyone, welcome back to another Explainer. I'm so thrilled to have you here today. Think of me as your personal medical coding instructor, because today we're diving deep into the complexities of transitional care management, or TCM. If you're dealing with patients who are moving out of the hospital and back into the community, getting these codes right, specifically CPT codes 99495 and 99496, is absolutely crucial. It's a real game changer for ensuring both continuity of care for your patients and bulletproof compliance for your practice. So grab a coffee and let's get ready to take some mental notes. Okay, let's take a super quick look at our agenda for today. We're covering 1. Intro to transitional care. 2. The 30-day global window. 3. The 3 mandatory service components. 4. Choosing 99495 versus 99496. And finally, 5. Essential TCM billing rules. All right, let's just jump right in. Section 1. Intro to transitional care. So, first things first, we really need to nail down exactly what qualifies as transitional care management. Because in the coding world, we can't just assume every post-hospital follow-up counts as TCM, right? The guidelines are incredibly specific. TCM is designed exclusively for patients moving from an inpatient facility. So think acute care hospitals, skilled nursing facilities, or rehab centers, back to their home or a community setting like assisted living. And here's the kicker. The patient's medical and psychosocial problems have to require at least a moderate or high level of medical decision-making during this transition. This isn't for your simple, routine discharge where they don't need any follow-up. Nope. This is for patients who need active, complex coordination so they don't end up right back in the ER. The official CPT guidelines lay this out perfectly. They confirm all those specific settings: inpatient hospitals, partial hospitals, observation status, the whole 9 yards. It explicitly notes that these codes are meant for when those medical or psychosocial issues demand a highly targeted level of medical decision-making. And honestly, it's nice because it defines home pretty broadly, including rest homes, assisted living, or even temporary lodging. Grasping this foundational definition, that's your very first step to getting these claims paid. Moving right along to Section 2, the 30-day global window. Listen, timing is literally everything with TCM. You aren't just coding a quick one-off visit, you're coding an entire comprehensive period of care. TCM operates on a very strict 30-day global post-discharge framework, and this timeline, totally non-negotiable. Day 0 is the exact date of discharge. The TCM period kicks off right then and runs for the next 29 days. Within this window, there are tight deadlines you simply have to hit. Within 2 business days, you need that initial interactive contact. Then, depending on how sick the patient is, your face-to-face visit has to happen between day 7 and day 14. If you miss these timing windows, well, you simply cannot report a TCM code, period. All right, Section 3. The 3 mandatory service components. Let's get to the meat of these requirements. To actually bill TCM successfully, you have to perform and, more importantly, document these 3 mandatory components. I like to think of them as a 3-legged stool. If even one leg is missing, the whole TCM claim just falls right over. You need the initial interactive direct contact, the ongoing non-face-to-face care management, and of course, the actual face-to-face visit itself. Let's break these down so you know exactly what the auditors are hunting for. First up is the interactive direct contact. The absolute most crucial point here is that it has to happen within 2 business days of discharge. Now, the method is actually somewhat flexible. It can be a phone call, it can be electronic, or it can be a direct face-to-face chat with the patient or their caregiver. The whole goal here is immediate triage, right? We're asking, are they stable at home? Did they actually pick up their new medications? Did they even understand their discharge instructions? This prompt contact is exactly what prevents those immediate readmissions. Just make absolutely sure your documentation clearly shows the date and the method of how you contacted them. Then we have the second component, non-face-to-face care management. This is basically all that behind-the-scenes magic that clinical staff and providers do to keep the patient safe. It's a ton of coordination. We're talking about grabbing and reviewing discharge summaries, chasing down pending lab tests, educating the patient or their family, and setting up community resources. It's comprehensive care coordination at its best. And, crucially, it involves medication management, which brings us to a massive compliance trap. Do not, I repeat, do not miss this in your notes. Medication reconciliation is a rock-solid requirement. The CPT rules explicitly state that you have to do medication reconciliation and management no later than the date of the face-to-face visit. You've got to compare what they were taking in the hospital with what they have sitting in their medicine cabinet at home and figure out what they actually need.
If your documentation doesn't blatantly state that this reconciliation was finished by the day of the in-person visit, boom, your TCM service is invalid. Okay, Section 4, choosing 99495 versus 99496. So, all the steps are in motion, you've kept the patient safe. Now, how do we actually pick the right CPT code for the visit? According to the rulebook, it all hinges on two interacting factors. First, what was the level of medical decision-making, or MDM, during the service period? And second, how quickly did that face-to-face visit happen after discharge? These two elements have to align perfectly for you to choose between the two codes. Here's how it breaks down. For CPT 99495, you need at least a moderate level of MDM, and you've got to do that face-to-face visit within 14 calendar days of discharge. Simple enough. But if the patient is a lot more complex and needs a high level of MDM, you're looking at CPT 99496. Now notice the catch here. For 99496, you have to see them much faster, within just 7 calendar days of discharge. Actually, think of it like this. If you have a high MDM patient, but you don't manage to see them until, say, day 10, you literally have to downcode to 99495 because you missed that 7-day window. Like I said earlier, timing is everything. And finally, Section 5, Essential TCM Billing Rules. Let's wrap this explainer up with these strict billing guidelines. Because honestly, understanding the clinical side is great, but knowing the billing logic is what keeps your practice paid and audit-proof. This quote right here from the guidelines, you should probably memorize it. It reminds us that TCM is highly exclusive. Only one qualified healthcare professional can report this service per patient during that entire 30-day window. So if 5 different specialists are seeing the patient post-discharge, only the provider who assumes the overarching responsibility for their transitional care gets to bill the TCM code. And no, you can't report it again if they have another discharge in that same 30-day period. Plus, there's another really vital rule about discharge day management. If you are the exact same provider who billed the hospital discharge services, codes 99238 or 39, you cannot double dip. You can't bill the required face-to-face TCM visit as a separate service if that encounter was essentially the hospital discharge. TCM is strictly for post-discharge management. Now, if you provide other E&M services on later dates within that 30-day window, sure, those can usually be reported separately. But that initial TCM bundle is fiercely protected. So that is the whole shebang. Master those tricky timeframes, really understand how MDM levels interact with face-to-face deadlines, and for the love of compliance, always make sure your medication reconciliation is documented on time. As healthcare keeps shifting toward value-based care, ask yourself, are there other transitional codes or practices just leaving on the table? Keep your coding accurate, protect your patients during these critical transitions, and don't forget to like, share, and subscribe to Decode Healthcare with Harshal.